Chapter 20 from John Murtagh. Okay, from this page, important thing is key symptoms of suggestive of cerebral infection are headache, dizziness, and altered consciousness. Then the meningitis is the inflammation of the meninges, pia and arachnoid, and the cerebrospinal fluid. Classic triad is headache, photophobia, neck stiffness. Other symptoms include malaise, vomiting, fever, and drowsiness. The organisms that cause are these, in which big three are Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitis that cause meningococcal disease. For investigations, we'll do lumbar puncture to assess cerebrospinal fluid, CT scan before lumbar puncture to see the safety for lumbar puncture, blood culture, then CSF microculture, PCR, specific serologies, right? Then these are the findings of CSF in meningitis. Glucose is decreased in bacterial tuberculosis, but in viral that is normal. Neutrophils are predominant in bacteria, while lymphocytes are predominant in tuberculosis and viral. Other thing is cell count, 100 to 1000 bacteria, 50 to 1000 in tuberculosis, viral में 10 to 1000. It's the lower limit is decreasing. Bacterial meningitis is basically a childhood infection for the children and neonates of age 6 to 12 months are at great risk. Meningococcal disease that is caused by the Neisseria meningitis can take the form of meningitis or septicemia or meningocemia or both, right? So if clinical features, if that is infant, fever, pallor, vomiting, altered consciousness, mental status, lethargy, irritability, refusal to feed, cold extremities, bulging fontanelles, Purzinki sign. These things are more prominent in infants. Neck stiffness is not always present, Cunning sign is not reliable, opisthotonus is very rare. This is Cunning sign. Pain in hamstring when inability to straighten leg on passive knee extension with hip flexion at 90 degree. This is Purzinki sign. Purzinki sign is reliable in infants. This is opisthotonus in advanced meningitis. Okay, if children are over 3 years or adults or adolescents, meningeal irritation is more obvious. That will show the symptoms of headache, fever, vomiting, neck stiffness. Later, delirium and altered conscious state also occur. Fulminating dramatic sudden onset shock purpura does not blanch on pressure. Purpura is more prominent in meningococcal meningitis, right? Usually due to meningococcal septicemia, also H influenza type B, Streptococcus pneumoniae, Listeria monocytogenes. Fine. For treatment, first thing is oxygen. Then we'll take blood culture. Then give the child bolus of 10 to 20 ml per kg of normal saline. And if signs of hypoperfusion are there, we'll give added bolus of total 60 ml per kg. We'll admit the patient for lumbar puncture, but before lumbar puncture, we get CT scan to assess safety. We'll give dexamethasone 0.15 mg per kg up to 10 mg IV state. Right? We can start at the same time or 15 minutes before antibiotics. Ceftriaxone 2 gram if the child is more than 1 month. 50 mg per kg up to 2 gram is the dose. IV state, then 12 hourly for 4 days, or cefotaxime 2 gram. Same thing, child 50 mg per kg up to 2 gram IV, 6 hourly for 3 to 5 days, right? If the meningitis due to Neisseria meningitidis, the suspected signs would be petechial or purpuric rash on trunk and limbs. Treatment would be benzyl penicillin 2.4 gram. Child, if there is child, will give 60 mg per kg IV up to 2 to 4 gram. Continue for 5 days. And we will give ceftriaxone 2 gram, right, for 5 days. Okay, one thing, in the treatment of meningitis, we were giving we were giving bolus, we were giving dexamethasone, we were giving ceftriaxone, right? So ceftriaxone was 2 gram for 4 days, or cefotaxime 2 gram for 6 hourly for 3 to 5 days. Ceftriaxone for 4 days or cefotaxime for 3 to 5 days. But in meningosemia, we will give the bolus and everything if the patient is in hypoperfusion and oxygen, everything. But for antibiotic, we'll give benzyl penicillin 2.4 gram for 5 days, or ceftriaxone for 5 days. Ceftriaxone was 4 days here, but it's 5 days here. Specific organisms, specific antibiotics for specific organisms could be like Streptococcus pneumoniae, benzyl penicillin, or cephalosporins. If they are group B Streptococcus, we'll give benzyl penicillin. If that is for H influenza, we'll give cephalosporin, right? Streptococcus pneumoniae, benzyl penicillin, or cephalosporin. Group B Streptococcus, benzyl penicillin. H influenza, cephalosporin, right? Streptococcus pneumonia, benzyl penicillin, and or cephalosporin. But for group B Streptococcus, benzyl penicillin, and H influenza, cephalosporin, right? This is the meningococcal rash. For prevention, we'll give the meningococcal vaccine. For viral meningitis, it is basically a childhood infection like bacterial meningitis. Most common causes are human herpes virus, the cause of Rhizola infantum, and enteroviruses like Coxsackie and Ecovirus. Most cases are benign and self-limiting, that we don't need the treatment other than supportive, but some, although there are fewer obvious signs of meningeal irritation that can mimic the presentation of bacterial meningitis. So lumbar puncture is important. PCR for enterovirus. If positive, we can stop the antibiotics at early time, right? Treatment is symptomatic with rehydration and analgesic. If that is herpes, we can give acyclovir.